Okay, I'm Andrea, as I was known this entire month because that was the name on my ID badge, but I go by Andy, and I'm a junior here at Colby, and I was in Tom's anatomy class last year, and I'm going to talk to you guys about my JanPlan experience. So I'm going to start off with my project. So my goal was to create a 3D vascular model for your lab that would be labeled, and I ended up running into a bunch of roadblocks along the way. So I learned a lot about the Institutional Review Board and IRB paperwork and learning about how difficult it can be to do experiments on humans. So I wanted to either volunteer myself or find a student, someone in the hospital who needed to have a scan done of their vasculature and a CT scan of their body. And what ended up happening was I found out that if we have these scans done on myself and they found something wrong, I would be liable, the school would be liable for anything that they found on it. So I had to fill out all these papers to basically state that if they found anything, what would happen, and consent forms, and Tom was really helpful, and Steve Diaz was really helpful through all this experience, but it's being reviewed right now. We got the paperwork in finally, so hopefully soon we will be able to finish the rest of this project. But the models that you see up here are what I made last summer, actually, and these are of mantis brains and electrodes that we put into them, and this is kind of what the vascular tree would have looked like. So just gonna pause there. Do you guys have any questions about my project so far? No questions? Okay. So I'm gonna talk to you guys a little bit about my experience with oncology and hematology. It's kind of weird how I ended up there. My grandma passed away last summer from cancer, and I read a really interesting book last summer about the history of cancer and treatments, and that's what kind of sparked my interest in oncology and hematology. So I spent Mondays and Tuesdays with Amanda McGarr in the hospital. She is a nurse practitioner. She works from 8 to 2, 5 days a week, and when she's working, she's on call. She consults patients, and when she's not working, she spends her time with her family. So she has a really nice lifestyle to work balance. So it is located in the hospital, and it's an oncology consulting. So the doctors in the hospital will contact her and the physician on call when they need something related to cancer to be talked about with the patients. So we would go on rounds in the morning and talk to the patients about their chemotherapy and why they were in the hospital, and we would talk to them about end-of-life care. So a lot of the patients who came in were very, very sick. So we would spend time with the patients and discuss what hospice was and whether or not we thought hospice was necessary. And a lot of the time, patients had very different conceptions and ideas about what hospice was and what hospice entailed. So it was very tough conversations that we had quite regularly with those patients. And then for the rest of the week, I would spend it with Susan Trafton in Outpatient, which was in a completely different building. So we would have daily check-ins before the patients would receive the chemotherapy treatment. We would check their vitals, ask them if they were having any extra symptoms from their chemotherapy. A lot of patients experienced nausea, constipation, just general discomfort, and any other just mental, psychological concerns they have. Cancer is obviously very stressful on them and their family. And so we would have education appointments also during the day. And during these education appointments, we would talk to new patients or returning patients about what their chemotherapy would entail, what to expect from it, how long they would be on it, when their appointments would be. And we also had immunotherapy education appointments. So immunotherapy came out recently in the last 5 years and is still going through clinical trials, and it's really, really cool, you guys. So basically what it does is it boosts your immune system specifically to the cancer. So when normal chemotherapy fails, they end up using this for patients, and it has very little side effects. And most patients don't even experience them. They just experience the normal. They'll come in, the discomfort of just coming in and getting IV fluids, basically. So they'll come in, get their immunotherapy, and they can live for years and years and years on this with no side effects, which is amazing because obviously chemotherapy and cancer treatment has in the past been very, very brutal on the patient. I had the pleasure of witnessing some bone marrow biopsies, which were when the patients were awake, and it's in the back of your hip. And it was interesting because most procedures you don't really want to be awake during, so these patients were very anxious and very nervous. And it was really cool to watch how Susan was so good at calming these patients down and making them feel safe and comfortable, even when like one of the bone marrow biopsies did not go well at all, and we ended up having to send her over to the hospital because of how badly it was going, but she was so calm during all of it and everything went so smoothly. It was really, really impressive to watch. And I also got to see one intrathecal chemotherapy treatment. So what they did was they went up to the radiology part of the hospital and they put in a needle in between their lumbar spine into the cerebrospinal fluid, and they took out 6 milliliters of fluid and they put in 6 milliliters of chemotherapy. So it's a preventative measure for patients who are really likely to get brain cancer. So they put in the chemotherapy into this cerebrospinal fluid and it helps to prevent cancer cells from forming there. So that was my time that I spent with Susan Trafton. Susan and Amanda were both very amazing people, and I learned that in oncology you really have to have that mindset of where you can leave what you experience at work. They're very positive people. They were people who were just good with other people. So Susan and Amanda were unavailable for a couple of days, so I ended up following a couple of physicians. So I followed radiology oncologist, Dr. Glenn Healy. He was a super goofy guy. He said groovy all the time, and when he went into patients' rooms, he would kind of like pop around the door and be like, hello. And I thought it was really fun to be with him. He was also the head of the Tumor Board, which I'm going to talk about in a second. And then I followed medical oncologist Dr. P and Dr. Julia. Dr. Julia was one of the only women physicians in the oncology part, which I thought was really bizarre to me that it was very male-dominated physicians, but mostly all the women, there were only women basically, PAs, nurse practitioners, and nurses. It was very hierarchical in my mind. And then I also got to follow a geriatrician because I have a soft spot for the elderly and I wanted to experience what geriatricians did in family practice. So I wanted to experience internal medicine with oncology, and then I wanted to kind of experience a little bit of family medicine. So I spent a day with him, also a really fun guy. So I got to go to tumor boards really early on Tuesday mornings, and tumor boards are made up of specialists, and the specialists are medical oncologists, radiology oncologists, pathologists, the surgeons, pharmacists, nurses, and data managers. So it's this giant group of specialists who are very well educated and very opinionated in what they think the patient should get for treatment with their cancer. And they all come together and review this patient's records, their health history, their social history, so whether or not patients can come in for treatment. There were some patients who lived really far away and needed radiation, and radiation usually happens day after day after day on smaller doses, and they ended up deciding to give larger doses in one day so that the patient didn't have to drive in all the time, or patients who don't have rides and can't drive themselves. So it makes the tumor board isn't just for treating the patient's medical needs, it's also their social. So they discuss the staging. It also counts as continuing education for these providers. So it provides an incentive for physicians to want to be a part of tumor board and to show up and be a part of this really great conversation. So some of my takeaways from this month were that we had a lot of elderly patients. So yes, old people are more likely to get cancer, but I noticed that we have a very older population in Maine. We also have a lot of patients who come in with family members, and physicians will only talk to the family members because a lot of them have hearing problems or just aren't as cognitively aware, and it creates this kind of ethical issue of whether or not they should be talking to the patient, and it kind of creates this ageist dilemma. I noticed that at least. We usually see younger patients who had breast cancer, patients who had a family history, or patients who had poor lifestyle habits such as smokers and alcoholics. So those were pretty much the only cases I experienced here in Maine of anyone under the age of, I want to say, 40 or 50. Everyone else was pretty much over that age. I did, like Livia, have the experience of having a prisoner come in. And it was interesting for me because usually we tell patients when we're going to see them next, and we weren't allowed to tell this patient when we were allowed to see them next because they could plan an escape. And we weren't allowed to treat them the same. Physicians were a lot more coarse towards them because they didn't want to be manipulated with them. It creates that ethical dilemma of they're a patient, they're a human too, but at the same time you have to protect yourself as a physician. So that was pretty interesting. I noticed more in inpatient that there was excessive and redundant amounts of paperwork, especially for the nurses. So you spend a lot of time filling out paperwork. Susan was really great about spending a lot of time with her patients, but it made it so that she had to do 3 times as much paperwork when she got home. Amanda had more of a schedule on a need-to-go basis, so she could do a lot more paperwork when she was in there. But I noticed the nurses were doing paperwork 24/7 because they had to do multiple checkups when they went in. So it's a lot of paperwork that you just don't expect from the medical institution. And as I talked about earlier with end-of-life care and inpatient, we talked a lot about, are we actually helping them with the interventions, and where do we draw the line? So where do you decide that the patient is actually benefiting from these interventions that we're doing to help them live, and when do you decide that you're no longer helping them and that you're actually harming them? It's a really tough call, and it really depends on every single patient. So what I learned was a necessary need for the mentality of like the go with the flow. So you have patients who miss appointments, you have patients from different backgrounds and beliefs, and I noticed that a lot with hospice, that you need to be able to just kind of let stuff roll off of you, because you're going to get hit with a lot of stuff that you just aren't expecting during your day. And if you don't kind of have that go with the flow and just kind of let stuff lay where it is mentality, it's very stressful. And when I followed a couple physicians who were very stressed out by that lack of control. And in medicine, you just have you have so little control with who you get and what they present with. And then the important skills of guiding and ending a conversation, because you have limited time with patients. The physicians especially have like 15 minutes per patient, and then they have to do all their paperwork for every single patient. So my favorite person was Dr. P. When he wanted to end his conversation, he'd be like sitting down at his computer, be like talking to the patient, asking them questions. And when he was done with the conversation, he'd go, "Well, it was good to see you," and kind of just like ask, "Do you have any more questions?" as he was like walking out the door. And, like, it's a polite way to end a conversation while still keeping on your schedule and making sure the patient feels like they're heard. I really enjoyed that. But most of all, it informed me about the lifestyle differences between inpatient and outpatient. With inpatient, when you're at work, you're working. With outpatient, you tend to take work home with you. And the difference between nurse practitioners, PAs, and doctors. So I got a really wide variety of experiences this January. So yeah, that's the end of my presentation. You guys have any questions? I'm still trying to figure it out a little bit. I want to follow some more family practitioners. When I followed the geriatrician, I was really intrigued by it, but I only saw him one day. So I would like to follow that a little bit more, but I am considering the PA route more seriously now than I was before, purely for lifestyle reasons. Spending all day with patients and then spending all night filing paperwork for patients. Yeah.
What is it about the structure?
Yeah, so with outpatient, you tend to fall behind a little bit, I noticed. Not everyone. So some people were really good at sticking to their schedule. And some people, I know personally, I would want to spend a lot more time with my patients than I would have available. And I would be very uncomfortable leaving when I needed to because I had to see another patient. Like, I would want to spend the time to make sure that I checked off all the bullets, make sure that they felt comfortable. And if I felt like I had limited time, I feel as though I wouldn't be able to do that as well. And with inpatient, you have that time because you don't have a set schedule. You see patients as you're needed. So you're able to spend that time. We spent one day talking about hospice with one patient for an hour and a half. You could never do that in outpatient. You would never have the time to do it. Yeah.
So you talk about the immunotherapy.
Yeah.
Is that treatment allowed to live comfortably while?
From my knowledge and experience with it, it does not treat it. It allows them to extend their life and their quality of life. So patients there are some cancers that are just really, really hard to treat, like liver and pancreatic cancer, because of the form of cancer they are very deadly, and they do not respond to immunotherapy. But other cancers, I can't think of any examples right now, respond really well. We have one patient here right now who's been on immunotherapy for 10 years, and he hadn't expected, like, beforehand he would have lived for 6 months to a year maybe. So it's really changed the game with cancer treatment. Oh, yeah.
Therapy. Broad stuff. only.
Yeah.
The last year that there was a talk about
Yeah. I think that was last year.
salmonella taking. Within the tenure, your career.
Yeah. We ran into a lot of patients who had issues with. We have social workers who are set up specifically to help patients with that. For example, taxi vouchers. They also have a volunteer service that picks up patients who can't drive themselves, who like have cars. For the cancer treatments themselves, a lot of people are on Medicare and Medicaid to help pay for all of that. I did experience a lot of struggle financially. We had some patients who didn't have the support system when they were inpatient to be taken home and receive treatment while they were at home. So they were sent to the rehab facility to regain their strength. And they knew when they were taken out of inpatient that they wouldn't survive when they were in rehab because they needed their chemotherapy so desperately. And that was purely based off of financial means. They didn't have the financial means. They didn't have the supportive means to be able to continue their chemotherapy treatment. That was really hard to witness. And it's really hard for the physicians to experience that because they know that this patient could possibly survive and cure this cancer, but because of their financial means, it's really, and it's definitely a really big flaw. Yeah. Sorry, I couldn't hear you very well. That I've had? Other than personally, yes. I've had quite a few health issues, so I've experienced a variety of medical already personally, but from the outside perspective, this is. Luckily, both Susan and Amanda are very supportive people, part of their job, obviously, but they're really good at checking in on me and making sure that I was doing okay. Like with the bone marrow biopsy, never like seen blood in that scenario before I sat down. They're totally cool about it. But yeah, I was really nervous at times. My first week was probably very, very stressful at first. But as I got used to it and started learning what to look for in patients and being able to actually have conversations with patients, it really, you get used to it, I guess. And you also learn that a lot of these patients are very happy. I was very surprised by that. A lot of the cancer patients are very well supported, feel like they're making progress, and are just genuinely very happy people. It's very rare that I experience a patient who is genuinely in a lot of discomfort and very unhappy. So that made it a lot easier for me, at least, feeling like I was helping.
Questions? Thank you.